Thank you. Thank you for the chairman to invite me here to do the talk about our experience about the TIVA in type A IMH and the selection criteria and the technique. So nothing for disclosure. As Frank just talked about, the acute type A intramural hematoma, usually the patient, if it's unstable, tamponade high risk, go to emergent open repair. However, in stable patient and in some country or in some area of the world still do the initial medical optimization with frequent radiology follow-up. However, 1/3 of these patients will progress to the full-blown of the dissection, and then some of them that require the timely open repair. So in the IRA study, actually, with the type A intramural hematoma and the classical LD dissection, actually they don't have difference in the in-hospital mortality, either in the medical management or the surgical management way. So we are thinking is that is there a remaining gap that a subgroup of patients with acute type A intramural hematoma who can really actually benefit from the TIVA repair. So that means that if you really find the intimate tear in the descending aorta with the retrograde type A intramural hematoma, is that good a patient can benefit from the TIVA repair. So these are the two examples that with the pre and the post TIVA repair for the acute type A IMH, but with the intimate tear in the descending thoracic aorta. So actually, in the literature review, you can see the first reported type A intramural hematoma repair is by the Dr. Dake, that we actually had included 3 cases with retrograde type A intramural hematoma in his first TIVA repair in the thoracic aortic dissection. And then found that several cases reported in some serious report after that. And the reason the IROD study, they also have the conclusion that early outcome for the acute retrograde dissection is that in selected patient and the primary tear in the descending aorta actually may be management less invasive with acceptable early result comparing to the classical ascending aortic repair. So actually we are pulling the first center retrospect data collection from 2010 to 2018, 18 October with the patient demographic, preoperative CT scan, operative detail, and the postoperative CT scan morphology. So a total acute type A intramural hematoma, 54 patients, 28 go to surgical, and then CT follow-up afterward. TIVA with 18, CT scan follow-up, and medical treatment with 8 patients, and the CT scan follow-up, and the 8 patient progressed to type A dissection in 4 patients, and still follow-up with a medical treatment in 1. And the material method, the primary endpoint, we found a 30-day mortality. We defined a 30-day mortality and 30-day mobility, including the cerebral vascular event, paraplegia, wound infection, and others. Secondary endpoints, the LD remodeling, the last CT scan follow-up, including the ascending and the descending aorta, and the all-cause mortality. In all these 3 groups, actually the medical treatment, you can see that still a little bit older than the other 2 groups in the TIVA and the open repair. And the surgery within the 24 hours in the TIVA group is 55% and 75% in the open group. And the hemopericardial presentation about half in the TIVA and half in the open repair groups. And the morphology of the ascending aorta between the 3 groups, it makes no difference in terms of the intramural hematoma thickness and the ascending aortic diameter. But for the descending aorta in the dissection, with the pure dissection in the TIVA group is 11 patients, in the open group is 6 patients, and medical group without a dissection. But with the descending aorta IMH, in the TIVA group is 7 patients, and most of the open group had the intramural hematoma in the descending thoracic aorta, and it makes a little bit significant difference between these 3 groups. In the TIVA group, most of the stent graft landing at the zone 2 and the 3, the length of coverage is about 16 centimeters, and 1 patient requiring intervention in the distal intima tear. And the open group, that half of the patient underwent the ascending aortic grafting, and half of them with the total arch or descending or ascending graft with the antegrade TIVA procedure, quite similar to the regular ascending aortic dissection repair. So the follow-up months, no pretty much different between these 3 groups, but with the 30-day mortality, we can see the TIVA group has no 30-day mortality. In the open group at 10